Hello, welcome to the webinar entitled Evaluating New Therapies in HIV. This program is jointly provided by North American Center for Continuing Medical Education, LLC, and DKB Med, LLC. This webinar is also supported by an educational grant from Gilead Sciences Incorporated, and we would like to thank them for their support. My name is Jeff Dunn. I am Vice President of Pharmacy for Magellan RX. Also presenting with me today is Dr. Laura Kogelman from Tufts Medical Center in Boston, Massachusetts. Our disclosures are listed here on this slide. Our goal in speaking with you today is to compare newer approved medications in terms of efficacy and safety, discuss pipeline therapies and newer fixed-dose combinations and their role in long-term HIV treatment, and finally evaluate shifts in focus in the newly updated treatment guidelines to recognize changes in the treatment population. I will now turn the presentation over to Dr. Kogelman.
Thank you, Dr. Dunn. My goal in speaking to you today is to review some of the background on HIV and where we stand with the epidemic in the United States at this point in time, and to give you some framework of how we treat HIV, the current guidelines, and what we can look towards in the future in terms of new agents coming down the pike. This first slide reviews the current guidelines for HIV testing. These have been out since about 2013. These reflect the U.S. Public Service Task Force guidelines. Other agencies have come up with fairly similar guidelines. The age range varies slightly from group to group, but the general recommendations are pretty similar. The idea is that all adolescents and adults between the ages of approximately 15 to 65 should be screened at least once for HIV infection. Anyone who's at higher risk, if they're younger than 15, or those who are older than 65, if they have certain risk factors, should certainly also be screened. The idea behind this is really just to make sure that everybody gets at least one HIV test at some point during their contact with medical care. All pregnant women in every circumstance should be tested for HIV during each pregnancy. Those who present very late in care, even during labor, should be tested at that time. And individuals who are at high risk for HIV, even if they've been tested earlier in their pregnancy, should be rescreened towards the end of their pregnancy. How often we should rescreen is something that hasn't really been determined, and that's when it does get a little bit more into risk factors. For certain individuals, screening every 3 months, every 6 months, once a year may be appropriate. Other individuals should be screened maybe just once. The idea of getting away from focusing just on targeted screening and just making it available to all individuals. And the guidelines also support the concept of opt-out testing, which is really that you're seeing your patient, you offer certain routine tests, cholesterol level, thyroid level, and HIV, unless the individual specifically does not want to be tested for HIV. In certain states, including Massachusetts, we don't have opt-out per se, we have opt-in. It ends up being a slightly semantic difference. But the whole idea is making HIV testing routine as part of normal care for all individuals. Why we've moved towards this is that we realized when we focused in on targeting testing as opposed to routine screening, we really were missing a lot of people. Sometimes patients won't disclose their risk factors to their provider. Some providers may not be comfortable probing into those more sensitive matters, and some individuals don't even know that they're at risk for HIV. If we're asking for risk factors, we could miss up to 25% of HIV-positive individuals. And if we're missing those individuals, we're not getting them on timely treatment, we're not improving their health, and we're not preventing them from transmitting to other individuals. Most patients in a lot of studies have really been much more accepting of routine HIV testing rather than targeted testing, and it makes it much easier to do. The other reason to try to screen people as opposed to doing this targeted testing is getting people diagnosed early. With prior testing strategies or places where they're not really engaged in early testing or screening, many HIV-positive individuals may already have AIDS by the time they're tested. As you know, HIV has a long latency period. It takes a long time for HIV to progress to the point where you're at AIDS, where the CD4 counts are less than 200. And by that point, you've lost a lot of time where you could improve the health of an individual. If we identify people early on in the course of their illness, it can lead to per-person survival benefits of over 11 years. It also decreases the chance that they could potentially transmit to other people. And HIV is a very different disease than it was 30 years ago. It's no longer a death sentence. It really is just a chronic illness. There are 6 classes of antiviral agents with 40 different products available. The HIV meds are far better tolerated than they used to be, There are fewer tablets. There are up to 6 single tablet regimens currently available, with more coming down the pike. They have better long-term efficacy and really have improved the life of people living with HIV. The other concept that I was alluding to is HIV treatment as prevention. So not only do we want to treat HIV early to prevent long-term complications associated with this infection, but we also want to prevent individuals from passing on HIV to their partners. There's been several studies that have focused on this, and we know that early initiation of antiretroviral therapy can significantly reduce the risk for HIV transmission to uninfected partners. One of the seminal studies was HPTN-052, and this studied serodiscordant couples in Africa. So one person was positive, one person was negative. And in individuals who were started on HIV treatment early, very soon after they were diagnosed, it reduced the rate of transmission by 96%. So really quite remarkable. Another study called the Partner Study, which included both heterosexual and homosexual partners with one person positive, one person negative. There were no linked transmission over a follow-up over 1 year per each serodiscordant couple if the HIV positive partner was virologically suppressed. That means if a person takes their HIV meds reliably, the viral load is undetectable, the likelihood of them transmitting to their partner is extraordinarily low. We can never say it's zero, but it really is markedly diminished. And this, of course, in the real world is important not for the partner that they're with who knows that they're HIV positive, but if individuals have multiple sexual partners who may not know their status, this is preventing transmission to all those individuals as well. So the guidelines have really reflected this data, continue to support the idea that not only should HIV treatment be started in individuals to help their own individual health, but should be started to prevent transmission. So where do we stand with HIV in the United States? Approximately 1.1 million people in the US have HIV. About 15% are unaware of their diagnosis. Now, about 4 or 5 years ago, this number was closer to 25%. So I do think that the drive for more routine screening really has helped. More people are being diagnosed, but we still haven't gone down to zero. In annual incidence is about 39,000 cases. This also has decreased slightly. It used to be closer to 50,000, so we are making some progress. The annual new infections declined by about 10% from 2010 to 2014. The population is still at high risk. There are some significant disparities. So young gay and bisexual men, especially those who are African American, are at the highest risk for getting HIV compared to other groups. Looking overall where HIV positive adults sort of fall, in terms of categories, it's still predominantly men in the United States. It's different in other parts of the world, but it's about close to 75% of individuals with HIV are male. In terms of age range, we see the largest cohorts are in that 50 plus years, which is because people are living much, much longer with HIV. We're seeing an aging population with HIV, but there still are quite a few in the younger age range. And we know in terms of new diagnosis, we're seeing a lot more diagnoses in the younger population. So the individuals who bear the biggest burden of disease in the United States are predominantly men who have sex with men. And then in terms of race and ethnicity, we see a large population who are Black and African American, as well as Hispanic and Latino. Although the numbers of whites look significant on this particular graph, when you think about the actual demographics of the United States and how many individuals are Black or Latino, there really is a large disparity there. We talk a lot about this concept of a cascade of care. So, and this has been promoted in other fields as well. We're seeing it spoken about a lot in hepatitis C. The idea is getting these people appropriately diagnosed, getting them into care, having them stay in care, and getting them successfully treated. So as you can see, we're still missing about that 15%. So we have 85% of people who are actually diagnosed. We lose about 20-odd% when we actually get them into care, to receiving care. We lose another percentage when they're to get them to stay in care. And then once people stay in care, because the meds are really, really effective, most of those are virologically suppressed. Once they're in care, once they're seeing their doctors, once they're on meds, they're going to do well. But the issue is trying to get those people into care and get them to stay in care. And this is a challenge that's being addressed in a number of different ways. I think most people have seen a graph like this at some point. It really is remarkable that at the dawn of the HAART era in the 1990s, when all of a sudden we had protease inhibitors, people just simply stopped dying, which was really amazing to see this huge change in such an abrupt fashion. And now we have a very, very large population of people aging, generally living healthfully, but a large population who are HIV infected, and we're dealing with an aging population dealing with routine healthcare, hypertension, diabetes, things like that, but a huge shift from where we were many years ago. What are we seeing in terms of morbidity and mortality now that we have such effective treatments? The life expectancy in patients started on effective antiretroviral therapy early in the course of their infection, when they still have high CD4 count, really approaches that of HIV-negative individuals. And this has been shown in several different studies. Mortality in most situations is not really directly AIDS-related. We're not seeing people dying of PCP and toxoplasmosis and those kinds of things like we used to. We're seeing other consequences of having ongoing viral replication. Having this chronic inflammatory state has been linked to other consequences, such as an increased rate of malignancies. And this is not just AIDS-related malignancies, but also non-AIDS defining malignancies, breast cancer, lung cancer, prostate cancer, all these kinds of things we tend to see in a slightly younger group compared to their HIV negative cohort, and usually with more advanced disease. We see liver failure, which is usually associated with co-infection with hepatitis C, although fortunately that's shifting with the incredibly effective meds we have available for that now. Non-AIDS related infections, cardiovascular disease. As I said, HIV is an inflammatory state that can lead to early onset atherosclerosis and lead to cardiovascular consequences. Because HIV gets into the cerebrospinal fluid very early on in infection, we do see some ongoing effects onto neurocognitive function, and we do see some of our individuals, especially if they were infected a long time ago, where they had ongoing viral replication, we're seeing earlier onset of neurocognitive decline. So where are we now in terms of what we have to treat HIV? The recommendations were updated just this October. They just came out. The general recommendations for treatment haven't changed that much over the last couple of years since they were updated. The biggest shift was about late 2015 to 2016, this definitive statement that all individuals should be started on antiretrovirals, regardless of their CD4 count. We no longer focus on a specific cutoff to initiate treatment, and this really comes from a number of different factors. So there were a couple of major studies called the START study and the Temprano study that looked specifically at this question. If you start people when they have high CD4 counts, how do they do compared to people where you hold off a little bit? And these are CD4 counts of 500. These are not low counts where people are close to having AIDS. And across the board, they saw that people did better the sooner they were started. Fewer incidents of cardiovascular events, fewer malignancies, and we really saw that it was beneficial to start patients early. The other reason this has started to shift is that the meds have gotten so much better. They're so much simpler to take. They have far fewer side effects than they used to, and they're also much more potent. We're not worrying as much about people breaking through their regimens, developing resistance, and having to deal with those consequences down the line. So this has really shifted the approach to HIV treatment. As I said, the other indication for treatment is to prevent transmission to other individuals. But of course, you have to approach each individual on a case-by-case basis. Although the guidelines may say they should start, a lot of HIV-positive patients have a lot of other issues going on. They may suffer from homelessness, from depression, addiction, all these kinds of things, and you have to make sure that all those other issues are managed before you can successfully start a person on therapy. They may be eager to start, but if they can't come to every appointment and have their numbers checked and make sure that they refill their meds consistently, it's not going to be beneficial to them in the long term. So we follow the guidelines, but we have to still approach each person as an individual. If a person does not have any other major psychosocial issues blocking their treatment, but maybe they're a little hesitant to start because they say, well, my CD4 counts are still pretty high, there are a couple of things that may push you a little bit more to try to encourage your patient to start therapy. So if they have any kind of symptoms related to HIV or AIDS at all, that would be an indication to treat. Even if their CD4 counts are high, if they're having significant weight loss, fevers, night sweats, lymphadenopathy, any kind of AIDS-defining illnesses, even if it's happening at a CD4 count that's much higher than you would expect, that person really needs to start on therapy. Individuals with very high viral loads really should be encouraged to start sooner rather than later. Rapid declines in CD4 count. So maybe you tested them the first time and their CD4 count was 1,000. 3 months later, it's 800. You really want to get those people onto therapy because clearly the disease is progressing. If they have active hepatitis B or C co-infection, those patients should be started. Hepatitis B, because most of the drugs that treat Hep B also treat HIV, so you don't want to put them on a regimen that will treat their Hep B, but only partially treat their HIV. Hep C, in general, people respond better to the medications. They develop less fibrosis if they're starting antiretrovirals. Individuals who have cardiovascular disease or at high risk for cardiovascular disease should generally be started sooner rather than later because of the inflammatory state that I mentioned before. People who present with very early onset HIV, primary HIV infection, acute infection, stopping the virus from progressing, from more cells from being infected, halting that whole process is beneficial. So starting these people sooner rather than later helps. Persistently undetectable viral load without antiretroviral, without antivirals, these are people that we refer to as elite controllers. So their own immune system is able to control their virus. There's always been a debate about what to do with these folks. Most people would probably start them on therapy. If there's a debate, if the CD4 counts are slowly declining, that would be a person you'd be more likely to want to start sooner rather than later. HIV-associated nephropathy, really the only treatment is HIV therapy. Pregnancy, of course, all pregnant women get started on antiretroviral therapy, and they continue antiretroviral therapy after they deliver. And age greater than 60 because of the other comorbidities that we've discussed before. There's a lot of medications available, as I mentioned before. There's technically more than 6 different classes of drugs. One is not an actual antiviral agent. It's what we call a pharmacokinetic enhancer, which we'll discuss in a minute. There are 40 different products, including 6 single-tablet regimens. The categories include the nucleoside or nucleotide reverse transcriptase inhibitors, and they do exactly that. They block the reverse transcriptase from transcribing the RNA. NNRTIs act on the same enzyme, but they do it slightly differently. They actually physically block the transcription. Protease inhibitors block the functional proteins from being formed appropriately, so the virus is not able to continue to replicate and infect other cells. Fusion inhibitors act to prevent the HIV from entering the CD4 cells. This particular agent is almost never used. It was a complicated injectable regimen that generally is not well tolerated. Entry inhibitors, there's currently only one in this particular class right now. It blocks another receptor on the CD4 cells to prevent HIV from getting in. Integrase inhibitors have really changed the face of HIV therapy. They block the HIV virus from integrating into the host cell DNA. These are very, very effective medications, extremely well tolerated, very few drug interactions, and as we get into the guidelines, you'll see that this has really been reflected in how we treat HIV. As I mentioned, there's this thing called a pharmacokinetic enhancer. There are 2 agents that do this. One is ritonavir, which is an older protease inhibitor that's only used for this function, and a newer one called cobicistat, which we'll talk about in a little bit. What they do is they block the metabolism of certain other agents, leading to higher levels of that other drug. So you get an enhanced level of that drug to make it more effective. And then there are multiple combination agents. Some contain only 2, some contain 3, some contain 4, and there are 6 that are fully complete regimens in one single tablet. So the guidelines that have just been updated this October really focus on the integrase inhibitor-based regimens. There used to be some other options considered as your first choice. Right now, the top 4 all contain an integrase inhibitor, and these are recommended for most people with HIV. They do make an exception, which I'll get to in the next slide, that some options may be better for other individuals, but all things being equal, you want to start with an integrase inhibitor-based regimen because they're so effective, so well tolerated, and so few drug interactions. So one of the recommendations is dolutegravir combined with abacavir and 3-TC, so that's an integrase inhibitor, 2 NRTIs. Abacavir is a particular drug that is linked to allergic reactions in individuals who have a certain HLA subtype, this HLA B5701. So that always has to be tested before you consider using abacavir for anybody. Another option is dolutegravir, not in a single tablet regimen, which the one above is, but combined either with TDF and FTC or TAF and FTC, and we'll talk about what those differences are shortly. Another single tablet regimen is elvitegravir combined with cobicistat, that's a pharmacokinetic enhancer, plus FTC and TAF, or potentially TDF, and we'll talk about that again in a few slides. And the other option is raltegravir, either as a once-a-day dose or a twice-a-day dose combined with TDF, FTC, or TAF, FTC. The other options that can be considered include some of the older agents like protease inhibitors, either boosted with ritonavir, as I mentioned before, or cobicistat. The advantage to combining with cobicistat is that now is a single, combined into a single tablet, so there's fewer drugs. Again, combined with either tenofovir FTC, either TAF or TDF. The other option for protease inhibitors is something called atazanavir, combined with cobicistat or ritonavir. Other options combining with another NRTI combination. NNRTIs plus 2 NRTIs. One is efavirenz combined with a tenofovir compound plus FTC. Efavirenz plus TDF FTC was the first single tablet regimen available. This is an option for some individuals. It's an older drug. Efavirenz has quite a few CNS side effects, can cause some changes in sleep-wake cycle, some anxiety, some very vivid dreams. So this has fallen out of favor for a lot of individuals, both providers and patients. Rilpivirine plus tenofovir FTC comes in a single tablet regimen as well. Restrictions on this is it cannot be used if a person has a higher viral load. So the viral load has to be less than 100,000 and CD4 count has to be greater than 200 cells. In addition, rilpivirine has some restrictions on use with proton pump inhibitors and has to be given with a full meal. So there are a few restrictions with that particular agent. Other options are an integrase inhibitor, raltegravir, given with a bacavir 3-TC as opposed to the tenofovir combinations. And then a few options if you want to have what we call a nuke-sparing regimen, so avoiding the NRTIs for whatever reason, either due to prior resistance or transmitted resistance, side effects, things like that. There are certain circumstances where you want to avoid the NRTIs. So darunavir plus ritonavir plus raltegravir has been studied. Only raltegravir given twice a day, and this should only be given again with a lower viral load and a higher CD4 count. Or lopinavir ritonavir, which is an older agent that we really don't use very much anymore, but it is a fixed drug combination plus 3-TC. These have been studied. They're not used very frequently in these combinations, but they do at least provide some alternatives for certain individuals. The IAS guidelines have not been updated yet this year from 2016. They're very, very similar to the current DHHS guidelines, although you'll notice here they make it even simpler. They've gotten the older version of tenofovir, the TDF, which we'll get into again in a few slides. They've gotten that off the list, and they only focus on the newer formulation, which is TAF. When we choose a new regimen, there's either initiation of first treatment, so the patient is treatment naive, they're about to start on their first therapy, or you're switching. When we switch, it could be for a couple of different reasons, but this is somebody who's already on therapy and there's some desire to change. The factors that influence your choice for a naive patient can be pill burden, how frequently the dosing is given, once a day versus twice a day. The size of the pills can be an issue for certain individuals. How compliant you expect that patient to be. When we're worried about patient compliance, that they may miss, quite a few doses, we often talk about using an agent that has a higher barrier to resistance, so it's more difficult to develop resistance to that regimen. You have to look carefully at any drug-drug interactions that other medications they might be on. What are some of the side effects? What are some of the potential long-term toxicities? Are there food requirements for some individuals? Eating a specific meal each at the same time every day can be challenging, and that's a requirement for certain of the agents. Is there any baseline resistance? Patients do get resistance transmitted from other individuals on occasion, about 15 to 20%. If they're pregnant or planning on potentially becoming pregnant, you want to choose a regimen that has a better track record in pregnancy. As I said, there's certain restrictions based on CD4 count or viral load at baseline. Do they have any allergies, in particular that HLA B5701 status, co-infections, as I mentioned before, and comorbidities? As we mentioned, there are some additional specific items that you think about when you're coming up with an initial regimen. We've touched on most of these before. I won't go into this in great detail, but again, there are certain restrictions if the CD4 counts are less than 200, if the viral load is greater than 100,000, if they're HLA B5701 positive. And then the other thing that is playing a little bit more of a role is the concept of test and treat, which is an area of active research. There's been a few studies that have come out supporting this idea that if you diagnose somebody and then you immediately get them on treatment, you may have better long-term outcomes, may be able to retain them in care longer, get that viral load to undetectable more quickly. It doesn't work in every situation. You have to have a full team to support an individual who gets that new diagnosis of HIV to get them onto treatment right away. But there are a couple of options that you may want to turn towards if you're going to do test and treat, because you will not have your genotype information yet. You won't know if the individual might have some underlying resistance. So you want to choose a regimen that has that higher barrier to resistance. They're less likely to break through even if there's a little bit of resistance. So using a protease inhibitor, darunavir, either boosted with ritonavir or cobicistat, plus a tenofovir-containing compound, or dolutegravir, which is an integrase inhibitor with what we think is a higher barrier to resistance, again, combined with tenofovir FTC. So that's a unique situation, but something that also has to be considered. Why would you switch a regimen? Of course, if the regimen is failing, a person is having a breakthrough of their virus and they're developed resistance, you need to choose a new regimen to get them to be undetectable. One of the big pushes these days is simplification. Some patients have been on more complex regimens for a long period of time because that's what was available when they first started treatment 5, 10, 15 years ago. If there's not a lot of other issues going on, there's not a lot of other underlying resistance, you can simplify their regimen. Get them from a twice-a-day regimen to a 1 tablet once a day. Really can improve their overall lifestyle. They get less pill fatigue, so that's something else that we consider. If a person has side effects, maybe they've sort of tolerated their side effects for a really long time because they didn't have a lot of other choices. Now with new choices available, you may be able to mitigate some of those. Minimize long-term toxicity. This is usually a doctor-motivated change. So looking at the regimen they're on, thinking about some of the long-term consequences, switching them to a regimen with perhaps lower risk of some of those toxicities. Patients going on new medications. Maybe now that they're in their 50s, now their cholesterol is elevated, they need to go on a statin. You may need to adjust their HIV regimen so they can safely be on that. Perhaps they're going on Hep C treatment. Sometimes you need to make adjustments in order to be able to give those new meds. And then again, as I said, any new comorbidities may affect your HIV regimen. So now moving on to where we have developed over the last couple of years with some of the newer agents that have come out and some of the newer agents that should be available really probably within 2018 and beyond. So before I get into that, I do have a question for the audience. Which of the following is the primary difference between TDF and TAF? I've alluded to there being some differences. There's all these choices. What are the differences? TDF is associated with lower renal and bone toxicity than TAF. TAF is associated with lower renal toxicity but higher bone toxicity than TDF. TAF is associated with lower renal and bone toxicity than TDF. TAF, but not TDF, is licensed for PrEP. I'll give you a moment to answer. Okay, so the answer is that TAF is associated with lower renal and bone toxicity than TDF, and I'm going to get into this in the next few slides. So 2015 to 2016 were really quite busy. There were quite a few new compounds that came out, and I'll break them down by category as I see it. So there were several new cobicistat-containing compounds. As I mentioned before, cobicistat is a pharmacokinetic enhancer that increases the levels of the drugs that it's combined with. So there's adavanavir Cobi, darunavir Cobi, so these are single tablet containing these two drugs, simplifying things a little bit, and then a full single tablet regimen of FTC, TAF, elvitegravir, which is an integrase inhibitor, plus cobicistat, and these all came out in 2015. And then there's the TAF containing compounds, FTC, TAF, elvitegravir Cobi, which I just mentioned, FTC, TAF, rilpivirine, and these two regimens, the elvitegravir and the rilpivirine regimens, replaced earlier versions of these combination single tablet regimens, which contained TDF instead of TAF. So it was just a slight switch. And then FTC TAF just on its own, that came out in April 2016. And then one that just came out within the last few months was a single dose raltegravir given once a day. Sorry, not single dose, raltegravir given once a day, 2 tablets at a higher dose. So TAF. This is a big change over the last couple of years, and it's a very interesting idea how they came up with this new medication. So tenofovir is the actual active compound. Tenofovir can't be given on its own. It has to be given as a prodrug. And the original prodrug was tenofovir disoproxil fumarate, much easier to say by TDF. And this has been used for a very long period of time, very effective medication, generally well tolerated by individuals, not a lot of side effects that an individual experience, but there have been some long-term toxicity issues associated with TDF. Renal toxicity and bone toxicity in particular. Patients with renal toxicity can end up having a Fanconi's-like syndrome. They can lose potassium and phosphorus, can occasionally progress to significant renal failure. And the bone toxicity can lead to decreased bone mineral density to really pretty remarkable levels and potentially leading to increased risk for fractures. The newer version of TDF is TAF, tenofovir alafenamide, also easier to say by just TAF. And the big difference is how it's metabolized. So whereas TDF gets converted into the active drug, tenofovir, in the plasma, where you have a lot of that active agent floating around, can get to multiple cells, can get into the renal cells, can get into the bones, can get into other sites, TAF is mostly converted to the active agent within the cells themselves, within the lymphocytes where you really want it to treat the HIV. So very, very significantly lower levels of tenofovir in the bloodstream, in the plasma. So you see less of those toxic side effects, less renal toxicity, less bone toxicity. The one potential advantage to the older version of the TDF is that it was associated with lower lipid levels. We've seen this compared to some of the other NRTIs as well. What this means in terms of clinical significance is really unclear. Whether that lipid lowering really is cardioprotective hasn't really been shown to be the case, but it is something to be aware of if patients are changing from TAF to TDF potentially, or from TDF to TAF. The TAF, as I mentioned, is available in 3 different co-formulations: the integrase inhibitor, elvitegravir, COBI, the rilpivirine, which is the NNRTI, and then just with FTC combined. TAF is also marketed as Zemliti specifically for Hep B treatment, just like TDF can be used for hepatitis B treatment. Per the IAAS guidelines, they have, as I showed you before, completely taken TDF off the list, so they only recommend FTC TAF compounds. The DHHS recommends combinations with tenofovir and then says that you can use either TAF compounds or TDF compounds. That's where they currently stand at this time. Another significant difference between TAF FTC and TDF FTC is that TAF has not been studied specifically for treatment for PrEP, so pre-exposure prophylaxis. There is a very, very large study going on right now looking into this. It's not clear that TAF gets the same levels of drug in the areas you're concerned about, so the vaginal mucosa, the rectal mucosa, et cetera. So it's going to take a few more years to get that data back, whether TAF will be a substitute for TDF for PrEP. So that remains to be seen. Another restriction is it can't be used, the TAF can't be used in creatinine clearance less than 30. The cutoff for TDF is less than 60. And there's limited data on TAF in pregnancy. It just hasn't been studied yet. So the phase 3 trials looking at elvitegravir, cobicistat, TDF FTC versus the TAF-containing compound, it's gone out to 144 weeks, and it's shown that TAF FTC was superior to TDF FTC, achieved viral loads of less than 50 copies, mostly due to a higher rate of discontinuation in the TDF arm. And this was likely due to renal toxicities more than anything else. At 144 weeks, participants in the TAF arm had significantly smaller reductions in their bone mineral density at their spine and hips than those in the TDF arm, so it really has been shown to have a significant difference. And through 96 weeks, the change from baseline estimated GFR and renal tubular function and discontinuation for renal adverse effects favored the TAF arm. Also at 96 weeks, they did show this fasting lipid levels, including LDL, HDL, and triglycerides, did increase slightly more in the TAF arm than TDF arm. No change in total cholesterol to HDL ratio, and the clinical significance, as I said, remains unclear. A phase 2 trial of darunavir, cobicistat, TDF FTC versus darunavir, cobicistat, TDF FTC. This has not been marketed yet, but it's we'll talk about it in a few slides. Showed very similar virologic suppression rates in each arm, and again showed benefit in terms of the kidneys and bones, less proteinuria, and less change in the BMD observed in the TAF arm. As I mentioned, there's the cobicistat compound. It mostly simplifies administration, so atazanavir, cobi, and darunavir, cobi are both single agents as opposed to giving atazanavir plus a second ritonavir pill. No data in pregnancy for either of these combinations with cobicistat, and the reason that's significant is as you advance in pregnancy, the volume of distribution and the way you metabolize drugs does change, and we have a fair amount of information of how to dose atazanavir and darunavir combined with ritonavir in those later trimesters. We simply don't have that information in COBE, so would not recommend it in those situations for those individuals. COBE is also marketed on its own as Tybost is the name. It's a single tablet. I haven't seen it used very much on its own. Its main function is being given in combination. But interestingly, although it boosts, just like ritonavir, COBE only inhibits the CYP3A4, whereas ritonavir inhibits several P450 enzymes. So there are some more drug interactions with ritonavir and COBE, but you still need to look very, very carefully whenever you're giving COBE to a person on other medications, because it still can interact. So still need attention to that. Another feature of cobicistat is that it inhibits tubular secretion of creatinine, leading to an increase in serum GFR and increase in serum creatinine and a decreased GFR, but it doesn't really affect renal function. It's very similar to what happens when somebody's given Bactrim. And usually this bump in creatinine hits up to about 0.14 over the several weeks of being on the med, and then it stabilizes. If you have a patient on one of these COBE-containing regimens and you see the creatinine continue to climb, it's something other than cobicistat causing it, but it's something to be aware of. So the other new regimen that I mentioned was raltegravir HD. So this is a drug that's been around for a long time. It was the first integrase inhibitor that came out. Its biggest disadvantage is that it's a twice-a-day drug, 400 milligrams twice a day. And so the company designed a newer option to give it once a day. When they previously looked into giving the 2 400 milligrams once a day, they had a significant number of failures. Changing it to 2 600 milligram tablets once a day did have good outcomes. It is still 2 tablets as opposed to a lot of our other options, which are 1 tablet. And by giving it once a day, some of the drug interactions have changed a little bit. So it cannot be given with calcium carbonate antacids, rifampin or etravirine. It should not be given with the once-a-day dosing of the raltegravir. It should not be administered with calcium carbonate, rifampin, or etravirine, whereas with the BID dosing, those drugs could be given in combination. So people have to be just a little bit more careful about that. And the HD dosing has not been studied in pregnancy, whereas whereas the BID dosing has been studied extensively in pregnancy and is one of the safer options that we can give. Some of the new agents that are going to have either already been submitted to the FDA or will be in the very near future. Darunavir, cobicistat, FTC, TAF, which is a single tablet regimen. A new integrase inhibitor, bictegravir plus FTC and TAF, and dolutegravir rilpivirine, which is a 2-drug single tablet regimen. Darunavir, COBE, FTC, TAF will be the first protease inhibitor-based STR, which is a really nice option, especially for people who have more drug resistance, because the protease inhibitors have that high barrier to resistance. May be a nice option for test and treat if you do not have that genotype available, since I do recommend darunavir. Boosted darunavir plus tenofovir FTC was one of the listed options. This would be a much simpler version of it, just 1 pill. Other than that, the drugs are all familiar drugs, nothing else new about that regimen. Bictegravir FTC TAF is a new highly potent integrase strand transfer inhibitor. Integrase inhibitor is how we usually refer to them. It's given without boosting, which is a big change compared to the other integrase inhibitor that's combined with FTC TAF, the elvitegravir, which has that cobicistat booster in it. So it's nice that you do not need to worry about those drug-drug interactions in the same way. It's non-inferior when it was compared in studies to dolutegravir abacavir 3TC, which is also marketed as a single tablet regimen, also non-inferior to dolutegravir plus FTC TAF. So dolutegravir is the currently available integrase inhibitor with what we think is the highest barrier to resistance, generally well tolerated. It's a really excellent agent for a lot of people. This compared very, very favorably to it, and offers a new single tablet regimen without that boosting and combined with FTC TAF. It also seems to have an even higher barrier to resistance. It's active against most integrase inhibitor-resistant variants. It has a very long dissociation constant from the HIV virus, which again suggests this high barrier to resistance. It's really hard for the drug to separate from the HIV virus, which makes it more difficult to develop that resistance. It's also metabolized, interestingly, by both CYP3A4 and UGT1A4. So there's few drug interactions because you really have to interact very, very strongly with one of those other enzymes to cause significant drug-drug interactions. So has some advantages potentially. And then dolutegravir ropivirine is kind of a paradigm switch for a lot of us. It's a 2-drug STR. All the other STRs are 3 to 4 drugs, including a pharmacokinetic enhancer in certain ones. And the idea is that maybe for some individuals, you want to have that nuke-sparing regimen. So not including some of those standard drugs that we use, TAF, FTC, abacavir, TDF, et cetera. It's an integrase inhibitor that we're very familiar with, dolutegravir, plus an NNRTI, which we're also quite familiar with, ropivirine. They looked at studies switching from a suppressive 3-drug regimen to dolutegravir ropivirine with excellent results in terms of maintaining viral suppression. So patients who were undetectable changed to this new option, still did extremely well. But it's not considered yet as a drug for naive individuals. This is only for switching, only for simplification for people where you want to potentially get rid of those nukes. It's not an option for naives. The only major disadvantages that persist with this combination are that there still are the same food restrictions and proton pump inhibitor restrictions because of the ropivirine compound. So ropivirine has to be given with a 400-calorie meal, and it has to be a meal. It can't just be a protein bar. 400-calorie meal in order for it to be absorbed appropriately, and it can't be taken with a PPI. So those restrictions will still apply for this combo regimen. It has a neutral effect on lipids, which is a nice advantage. So there may be a subset of people where this would be a nice option for them. And some of the new things that we're anticipating, these are familiar classes, just new versions of them in phase 3 development. So doravirine is an NNRTI. Cabotegravir is an integrase that has both oral and intramuscular formulations, known as CAB-LA, long-acting. A cabotegravir ropivirine LA co-formulation given IM, and lamivudine combined with dolutegravir. The doravirine is a once-daily NNRTI that has a high barrier to resistance and retained activity against first-generation NNRTI mutations. It's being developed as a single-tablet regimen with, interestingly, TDF and 3TC. The main motivation for that is due to TDF and 3TC becoming generic, using that for cost issues. It's interesting because most of the other regimens contain TAF as opposed to TDF, so it'll be interesting to see how that goes. It's been shown to be non-inferior to darunavir, ritonavir, and efavirenz TDF FTC-based regimens in naive patients. It seems to be very effective. No major side effects so far. So it's nice to have another agent in that class, particularly for people who have resistance. What role it's really going to play compared to some of the agents, it's not clear yet. One of the more exciting ones that's being developed is cabotegravir, which is, again, an integrase inhibitor that has both a PO and an IM formulation. The CAB-LA, the IM form, has a very, very long half-life, and they actually can detect levels of the drug up to a year after dosing. You need to do an oral lead-in phase before you can do the injectable version because you need to screen for adverse effects. So you don't want to give a patient a med that they're basically going to be on for a year and then find out they have side effects. So you always have to do this lead-in period. It has a very similar resistance profile to dolutegravir, which is a good profile. It's been studied in combination with long-acting injectable ropivirine for naive patients with very high rates of virologic response and good tolerability. They're currently looking at either giving it Q4 weeks or Q8 weeks. There were a few more virologic breakthroughs in the Q8 week study, but they haven't completely ruled that out as an option. So continuing to be developed. One of the other areas where CAB-LA may really have a role is in PrEP, so the pre-exposure prophylaxis. And currently the only option for PrEP is TDF FTC, and it is quite effective. This is a different approach, which is the drug is given every eight weeks. They've shown that for PrEP, the every 8 weeks seems to work fine after you do that 4-week oral loading dose. So for some individuals, maybe a nice option. They only have to come in to see the doc every 8 weeks to get their PrEP dose. Again, for patients who would be treated with the combination cabotegravir and ropivirine, it's either every 4 weeks, maybe every 8 weeks. It is a large volume to be injected. So again, I think once it gets closer to being licensed, you may have to find a specific individual where it's really appropriate for them. So more remains to be seen, but it is an exciting new approach to treatment and prevention. The last new agent in phase 3 development is dolutegravir and 3TC. It's a single tablet regimen, and it's been studied both in switch and in naive. So in patients on a fully suppressive regimen, switched to dolutegravir and 3TC, there was no significant virologic breakthrough, so it worked pretty well. And there was a pilot study, so a very small number of patients so far, and it showed efficacy in naive patients with lower viral loads, less than 500,000, that it did seem to be effective. So it might be an option for patients who can't take NRTIs due to tolerability or resistance issues. I think it's a challenging concept for a lot of us because 3-TC is not a very potent agent all on its own. So we're giving a very potent regimen with the dolutegravir arm with just one other medication combined. Again, I think we need more data on it to sort of see where it's really going to go. But a lot of new approaches to HIV management. And then some of the newer agents in totally different classes that are in phase 3 right now, still a long way from being submitted, but really interesting. There's ibalizumab, which is a monoclonal antibody. It blocks HIV entry, so different from the older HIV entry inhibitor that we have. It attaches to the CD4 receptors and stops the changes that have to occur to allow the virus to enter the cell. It's active against both CCR5 and CXCR4 tropic viruses, which is interesting because the other CCR5 receptor blocker obviously only blocks CCR5. Has a very long half-life. It does have to be given by infusion. Right now it looks like every 2 weeks. And this is really only for people who are highly treatment experienced with extensive resistance. And although we do not see as many people failing these days as we used to, there are definitely still a population of patients who have very advanced disease with a lot of resistance mutations and need other options if they've already kind of burned through the other options we have available. So this is very exciting. It's a very new approach, and I think maybe a good option for some of our more complicated patients. And there's Pro-140, which is an IgG4 antibody that blocks HIV entry by binding to the CCR5 receptor. So it acts differently than the current CCR5 receptor blocker. It is active against a virus that has become resistant to Maraviroc, which is another CCR5 receptor blocker. So again, a new class of drugs, a new option. This would be weekly subcutaneous injections. So as you can see, there's a real shift of trying to get away from oral agents and shifting to parenteral methods. So there's a lot more that are still in early phase development. HIV continues to be an area of active research and active development. So the takeaways from I know a lot of information. One of the keys is that we are still seeing HIV infections. They are particularly in young MSM of color being disproportionately affected. So it is an ongoing problem. This is not something that we can become lackadaisical about addressing. The guidelines recommend that all HIV positive individuals start antiviral therapy regardless of CD4 counts. The guidelines clearly emphasize treatment regimens that include an integrase strand transfer inhibitor and focus on simplicity, tolerability, and efficacy. Products approved over the last 2 years include 2 single tablet regimens, new versions of familiar agents to improve pill burden and dosing frequency, as well as several compounds that include TAF, which is the new prodrug of tenofovir with an improved safety profile compared to TDF. New agents likely to be approved in the next 2 months include 3 single tablet regimens. They're expected to be well tolerated and efficacious. At this point, I will turn the presentation back over to Dr. Dunn. Thank you very much for your attention.
Thank you, Dr. Kogelman, for that excellent presentation. I will now discuss incorporating new therapies into formulary, what to know in advance of new guidelines. I will also address managed care issues and how we can incorporate these newer therapies into formularies. This brings us to our next audience question. The question is, HIV is the blank most expensive specialty drug category for payers. The choices are 1st, 3rd, 5th, or 9th. So this slide shows the answer to that question. HIV is a top 5 category of specialty drug spending. This data comes from the Express Scripts Drug Trend Report from 2015, but newer iterations show similar trends. So HIV right now is the 5th highest specialty drug spend category for payers, with an average per member per year drug spend of $31.53. Meaning that for every member that we provide insurance for, $31.53 of their premium goes towards covering HIV medications, whether or not they have a diagnosis of HIV or are using HIV medications. And then the last column shows the year-to-year trend in cost. So between 2014 and 2015, there was a 16.6% increase in trend. Some of this was driven by an increased utilization, but most of it was driven by an increase in cost. So every year we are seeing double-digit increases in HIV, similar to what we are seeing in other specialty categories. Current and relevant issues regarding HIV management include the fact that HIV is still a quote-unquote hands-off category. There is not much management, including things such as prior authorization step therapy. Most of the management is done just through tiering. It is a high-cost category, but has relatively low utilization. Again, as we just saw, it's the number 5 specialty cost category under the pharmacy benefit. Most payers have many of the drugs for HIV in Tier 2 or a preferred brand tier. This is despite the fact that there is no contracting, and we really haven't gone beyond tiering and making preferential decisions in specific categories. So this begs the question, does this provide an opportunity to payers to manage HIV differently? And we'll talk about that. The impact of new branded agents is high. Most of the new agents are combinations, and these come at a significantly higher cost than some of the monotherapies. This also makes it somewhat difficult to make comparisons. The impact of generics and pending generics is somewhat unclear. We will not have generic combinations for a while, and this also begs the question of should combinations be broken apart. I know Dr. Kogelman has some opinions on that. The issue from a payer perspective is we absolutely do not want it to impact compliance, but pill burden has changed. Going from 1 tablet to maybe 2 or 3 may be different than going back to 15 or 20 like we saw a decade ago. So this will potentially help patients that are still, especially on non-single tablet regimen combinations. And I'll show some of the data about what patients are using in a minute. These non-single tablet regimen products are used in combination, and the price should consider the combinations. Another question is HIV and single tablet regimens a specialty category? So should we as payers be placing them on higher tiers or co-insurance tiers because of their escalating costs, which is a different strategy than what has historically been done, with, again, most payers covering many of these on preferred branded tiers or non-specialty tiers. The HIV medication history is shown here. Multiple drugs have been approved for the treatment of HIV in the last 10 years. I want to point out the drugs that are in circles. These are the single tablet regimens. We had a triple back in 2006, and then in the last 5 or 6 years, we've had 3 other single tablet regimens launched. So looking forward to the HIV medication pipeline, the top part of this graph shows the pending LOEs or loss of expiries or the pending generics, and we're expecting many generics over the next 5 years. And the bottom in red shows the pipeline for brands, and there are a lot of brands also being studied, and this includes many more combinations or fixed dose combinations of medications. So as I alluded to a minute ago around market shares, the HIV medication market share is shown here. This slide shows the prescribing trends indicating the fact that STRs currently dominate as first-line therapy. If you look on the left, STRs in 2013, about 33% of the HIV market was single-tablet regimens. It's expected by 2022 that will be over 50%. So that is a good thing for compliance and outcomes probably, but this also speaks to the fact there are 50% of patients not using single-tablet regimens, and so there might be a different opportunity there. So in summary, there are currently 4 single-tablet regimens on the market, but upcoming STR launches are anticipated that will severely intensify the competition, and which brings in other potential contracting and preferential decisions that have not been a viable solution to date. So we have seen that HIV is a top 5 specialty category. HIV medication costs and ranges are listed here, broken out by drug class. The bottom line is the fixed dose combination pills, and as of a couple of months ago, the single tablet regimens ranged anywhere from a little under $1,400 a month to over $2,500 a month with increasing prices. And so this equates to, if you look at total cost of care and total cost of regimens, between $30,000 and $40,000 a year. So this is comparable to inflammatory disease and some of the other high-cost specialty categories that are tightly managed. One of the most important HIV issues, including for payers, is adherence. HIV non-adherence and treatment failure predictors were studied in the PEARL study, which included over 1,500 patients in 9 countries on 4 continents. The study reported that once-daily regimens had lower non-adherence rates than twice-daily regimens. That's kind of a double negative. So another way of saying that is single-tablet regimens provided better adherence rates. But this, for whatever reason, it seemed to attenuate over time. So this stresses the fact that early education with patients, HIV patients on STRs is crucial. The study further found that non-adherence is associated with hard drug and soft drug use, unprotected sex, worse quality of life health, and younger age groups. So these are all things we should be watching for when we're working with our HIV patients, and acknowledge that there are potential risks that increase the likelihood of a patient being non-adherent. Clinical and economic outcomes of non-adherence in HIV were reported in a study by Munakata. It used a Markov model that evaluated ideal versus typical adherence scenarios. With typical adherence, patients lose 1.2 quality-adjusted life years that could be gained with ideal adherence. Improving adherence to ideal levels is cost-effective at $29,400 US dollars per quality-adjusted life year gained, and as much as $1,600 US dollars per patient could be spent on an intervention to improve adherence to ideal levels, and the incremental cost-effectiveness would remain less than the standardly accepted $50,000 US dollars per quality-adjusted life year gained. The authors concluded that typical adherence with HART reduces quality-adjusted life expectancy by 12% compared with ideal adherence. Interventions to improve adherence appear to be highly cost-effective use of resources. So this is where payers come into play, and I'll talk a little bit about how we can support providers in improving adherence in a few minutes. So strategies for improving medication compliance and outcomes should be a focal point for everyone working with HIV patients. Strategies include pay for performance, strengthening the patient-provider relationship, empowering patients, and integrating communication channels. And I'll talk about a couple of those in more detail. The first is patient empowerment. Patient empowerment strategies offer more than well-intentioned advice or scare tactics to prompt patients to adhere to treatment guidelines, and they address the complex interaction of a number of things. There are a lot of things that our patients are dealing with, and they include cues to action, their perception of benefits and consequences, expectancies, cultural and environmental influences, their ability to be self-maintaining, their state of readiness to change, their ambivalence, and or implementation interventions. So we cannot tell the patient what to do. To be successful, the patient really needs to be part of the plan and buy-in. Otherwise, anything that we would do will not be successful. Integrated communication channels are also crucial. Multi-provider level communication with patients regarding the importance of medication compliance includes, at a minimum, physicians, pharmacists, nurses, and care managers. And providers, all of those listed, must communicate respect for the patient's perspective of their condition, provide rationale for any recommended treatment, negotiate a plan and anticipate and address problems, discuss adherence at every visit in a non-judgmental way, and establish a collaborative process of problem solving. Every interaction should be communicated to the other healthcare team members listed above. Other pharmacy management strategies in HIV include especially pharmacy integration with payers and providers, case management using a more active and educated intervention. This really should be interventional rather than the typical reactive format that we're used to. Patient support programs could be included in the benefit design. So for example, if we know that there are coupons or other programs that we are educating the patients about that through the benefit design process. And compliance monitoring needs to be multifactorial, including the pharmacist having quarterly interactions. So things such as reporting, meetings, and review of data should be done on a continual basis. This is due, again, to the clinical consequences of non-adherence. Examples of specialty pharmacy strategies include benefit management, utilization management, specialty pharmacy tools, medication therapy management, and contracting. So benefit design includes tiering, and I'll talk a little bit in a minute about what one of the trends that is occurring in benefit design with most payers right now. Utilization management includes the appropriate use of prior authorization, step therapy, and quantity limits. These are typically run through the P&T committee. Medication therapy management is really, really important when it comes to managing HIV patients, given the comorbidities and the drug interactions and side effects associated with these medications. And then contracting. As I mentioned a few minutes ago, contracting is not common in the HIV space. This, I think, in my opinion, will change moving forward. But in order to make it impactful, we really do need physician help in order to address the high cost of HIV medications. Otherwise, we will not have success in having conversations with our pharmaceutical company partners. Specialty care management is something we can all do also. It is essentially a bulked up medication therapy management program. It includes or emphasizes integration with care management, coordinating site of care, ensuring appropriate dosing, ensuring adherence, again, at every visit, education on appropriate use of medications, and managing expectations. Required actions include designing the workflow, analyzing the data, and then training the personnel. So it's really important that our professionals that are on the phone talking to patients fully understand the nuances in treating HIV and are respectful of the patient's condition and are educated enough to collaboratively work on a care management program with our patients. And at that point, again, the key is to retouch base with the provider. So any recommendation or patient contact that is done through a care management or MTM program should be communicated back to the physician. So I mentioned a minute ago one of the changes that is occurring in the industry concerning benefit design, and that is the use of multiple specialty tiers. This is a really hot trend right now, and it will probably impact HIV medications in the future if it hasn't already. So this data comes from the EMD Serono Specialty Digest of a couple of years ago, and at the time it reported that 12 of 36 health plans with a specialty strategy have a multi-tier specialty cost share. This accounted for about half of the covered lives, but it also said that 93% of PBMs plan to increase use of specialty tier in the next 24 months. So we're right there. So if payers don't have specialty tiers now, more than likely they're evaluating it, and more than likely they will have multiple specialty tiers in the future. So a typical structure for that is a 3-tier, similar to what we've seen historically on the traditional side, where Tier 1 would be generics, Tier 2 would be preferred specialty, and Tier 3 would be non-preferred specialty. So and this begs the question of, is this appropriate for HIV? Most of these drugs have been managed in non-specialty tiers, but they are definitely priced like specialty medications. So if we move drugs to higher tiers, it gives us the leverage potentially to contract and to do things differently, but it also potentially increases the member out-of-pocket, which negatively impacts adherence and outcomes. So we have to do this very cautiously, but it does. This will be an issue moving forward with HIV, the transition from traditional to specialty. So in summary, the key takeaways are that HIV has been a hands-off category. This is likely to change due to the pending generics, increasing cost trends that we talked about, and more single-tablet regimens that are entering the market. Adherence and subsequent outcomes is an issue and will always be an issue. Clinical management can be better. An integrated approach with all the different stakeholders is crucial. Specialty MTM is one payer strategy that can have a positive impact on outcomes. And all stakeholders need to be involved. This includes patients, providers, payers, and pharma. Pharma historically has not been the stakeholder involved in the management of these patients, but given the costs and the need for contracting and risk arrangements and other things, we need to figure out how we can all work together. And the point of this is that if we are not collaborating, then hard decisions will be made that will potentially impact all of the other stakeholders. So I think it would be better to be proactive and work together on these issues before it's too late. So this concludes my portion of the presentation. I will turn it over to you, Dr. Kogum, again, if you have any final thoughts that you would like to share with us today.
Thank you, Dr. Dunn. I have a few final thoughts to share with you. With the new drugs that are coming to market, cost containment will continue to be an issue that needs to be addressed, as I think has been clear. However, many of the agents that have been developed or are in development offer improved safety profiles which will benefit patients over the long term. The favorable safety profile of TAF-FTC in particular has been reflected in the evolving IAS and DHHS guidelines, and there's been a strong emphasis on single-tablet regimens or at least once daily dosing, as has also been reflected in the guidelines. New agents likely to be approved in 2018 are all single-tablet regimens that appear to be highly efficacious with limited toxicity. And starting and keeping patients on these highly efficacious, well-tolerated regimens with minimal toxicity is really critical to long-term compliance, which ultimately benefits the long-term health of people living with HIV who can now expect close to normal life expectancy. Thank you very much.
Excellent. Thank you, Dr. Kolgeman. I would like to thank everyone for attending this webinar. We will now open up the question and answer session. Hello, everyone. Thank you very much for joining us for today's webinar. My name is Jeff Dunn, and I will be moderating today's question and answer session. And I'm joined by Dr. Kolgeman. Thank you. As a reminder to the audience, if you would like to ask a question of either myself or Dr. Kolgeman, please type your question into the question box on your screen. So our first question comes from the audience, and I think I will direct it to you, Dr. Kolgeman. And the question is, do you think the more recently approved medications offer a significant advantage over earlier regimens?
Thank you. I think some of them may. I think particularly one of the medications that's coming down the pike potentially, the bictegravir TAF FTC, offers some nice advantages that it is another single tablet regimen but doesn't require boosting and doesn't have some of the other adverse reactions that we concern ourselves with the bacavir a little bit. So that has some nice options that may be good for a certain subset of people. The fact that there's one single tablet regimen including a protease inhibitor I think is very encouraging. because we don't have anything in that class, and may be a particularly good option for people who want to start therapy without getting a genotype results back yet. And again, the newer agents that have come across over the last year or so, I think that TAF does seem to offer a significant advantage over the older version of TDF, at least so far as we can tell so far. Seems to have a lot less kidney toxicity and a lot less bone mineral density toxicity than the older formulation. So I think there definitely are some advantages with the newer agents.
Excellent, thank you. We have a question around generics and STRs, so maybe I'll try to set this up and then ask your opinion, Dr. Kolgeman. So we do have some generics on the market now. We do have some other pending generics, some of which are combination therapies. Is it ever appropriate to maybe break up combinations or single tablet regimens in an effort to potentially save the patient money by using generics that are usually on generic copay tiers?
Do you want to take that one to start, or do you want me to take that? Or
yeah, I mean, if you wouldn't mind maybe giving your opinion on maybe the potential for breaking up combos if we can get to generic, and what your clinical feeling is about that.
Yeah, I mean, I think it's really hard because I think twofold. One is that one of the hugest advantages of the meds that are being developed and that have been developed over the last several years is the fact that it's one pill once a day, and that is really very appealing to patients, especially in a population where we do worry about issues of compliance, and compliance is so critical to long-term health in HIV, that if we start breaking them up into more pills, even if it's still once a day, I do worry that that's going to affect long-term compliance. And the other thing that concerns me is the ones that are generic or going to be generic are not necessarily the drugs that we're favoring now. So, for example, the TDF version of tenofovir, which does seem to have disadvantages compared to TAF, I'm not sure I'd want to take a patient who had potentials for complications and put them on something that may lead to more complications down the road. I mean, there may be a select few who you could take maybe break it up into just 2 different medications if that's available. If they're already on those meds, they don't have any other problems going on. But taking someone from a very safe, effective, well-tolerated, simple regimen and making it more complicated with potentially more side effects, I think we may be looking at more complications down the line from doing something like that.
Great, thank you. And I'll just add that, if looking at the utilization data, we still have the majority of patients who are on combination non-single tablet regimen agents. So there is going to be a role for generics. We have to be careful with that. But I think that if maybe if we have conversations with our specialists, and as long as we have the care management programs in place, and we're not going to BID or TID regimens, there might be an opportunity to have a conversation, because this is a top 5 specialty spend category, and it's really the only top 10 category that's not managed. So maybe just kind of an ancillary question, Dr. Kolgeman, is now that we have more and more single tablet regimen options, is there an opportunity, and I'm just going to throw this out there, because I think, I maybe have an opinion on this also. Is there an opportunity to, in exchange for maybe lowering drug prices from the manufacturers, is there an opportunity to pick a couple of those as preferred regimens and try to direct initial single tablet regimen decisions to those agents, or is that inappropriate?
I think it could certainly be considered, and I do think particularly with the new regimen that should be available, the bictegravir TAF FTC would be appealing in that way, because when we're trying to make decisions of which drug to start a patient on, we have to balance drug-drug interactions, viral load restrictions, food restrictions, HLA subtypes, all these other kinds of things that help us decide between some of the other single tablet regimens. This newer regimen doesn't have a lot of those other issues with it, so that may have an advantage. And if we say, okay, it's a newer drug, so it may be coming out as a more expensive one, but that would probably be the easiest pathway to go. The other one's trying to restrict them because there are such unique characteristics to the 3 main single tablet regimens we have. Saying using one over the other just may not be feasible, because there's a significant amount of thought that has to go into choosing one over the other.
I think, again, I think it's worth conversations with our specialists, just because historically, based on market shares and manufacturers, we haven't had a lot of opportunity to potentially prefer and contract and lower costs. But as multiple manufacturers enter the space with single tablet regimens, it is at least it's a different conversation.
Yeah.
But
I think it's interesting that you said that you said from your data that a lot of people aren't necessarily on single tablet regimens. That may really be a testament to sort of regional differences and sort of the population that's treating HIV. So I think, you know, based in Boston, where we have a lot of major academic centers, I think we're very much a lot of us are very much shifting to the newer regimens and are really focused on that. Whereas if people are managed by not necessarily HIV specialists, they may be using other regimens that aren't the single tablets, and maybe then that conversation makes more sense for that kind of group. I think it's hard for us who've already sort of moved forward to, like, let's get this newer, simpler regimen, and then backing off from that would be hard. But maybe there's different populations that would have more of a role for.
You know, good point. If you're, you know, for example, a national payer and have lives all over the country, it's a good point. I'm going to try to squeeze in one more question and then wrap up. It's from the audience again, and I'll direct it to you, Dr. Kogelman. Do you have any updates on HIV vaccines?
You know, that's a great question. I don't personally. I'm not. It's not an area that I particularly do research in. I know there's a lot of work that's ongoing. I haven't heard anything particularly recently that has sort of shown it's any closer to really being close to being used in the market. It's still very much in development. I think a lot of the focus and research has been on PrEP, so preventing HIV. There's a big push towards that, but I'm not sure about where we are with the vaccine. Sorry about that.
Perfect. Unfortunately, I don't have anything else to add either, but interesting concept. But I would like to thank all of our listeners for attending today's webinar. Importantly, to receive credit for today's activity, you do need to log on to the website, which is www.naccme.com. Again, naccme.com. There, once you complete a short 10-question test and evaluation form, you can immediately print your documentation of credit. This concludes today's webinar. Thank you again for joining us, and have a great day.